Okay, so welcome to the electrocardiogram module. So electrocardiogram or ECG or EKG, just depends. It's spelled both ways, with a K or with a C. It means the same thing. Okay, so we're going to be talking about the electricity of the heart. Okay, and the electrical waves that it produces um, on the leads that we attach to a patient. Okay, so let's just look at this very uh, simple slide here in terms of the electricity. So we have, uh, we need electricity for the heart in order to lead to depolarization of the muscle chambers of the heart. So the atria and the ventricles. So without electricity, the chambers aren't going to depolarize. There's going to be no contraction. Okay? And that's not good, right? We need contractions of the ventricles to maintain blood pressure. Okay? So let's just look at these waves. So the first wave is the P wave. And the P wave appears on an ECG or a rhythm strip or any electrical readout. When we're looking at the heart electricity, we're going to see a P wave. Remember, we're talking about normality right now. We're not talking about abnormal rhythms. We'll talk about those later. So a P wave is generated by atrial depolarization. Okay, so the muscles of the atria depolarize and we see it as a P wave of electricity. Okay, notice it's pretty small, right? So the atria don't have thick muscle layers, so they don't generate a lot of electricity, and there's the P wave. There's a bit of a break after the P wave. We're going to call that the PR interval. We'll come back to it. Remember, there's going to be repetition here so you understand it. So the PR interval, that flat line between the P wave and the next wave called the QRS complex. The QRS complex is depolarization of the ventricle myocardium, so the ventricular myocardium, left and right ventricles together, right? And then there's a flat line again in terms of the electricity, so it goes back to the what's called isoelectric line, so right back to the baseline, and we're going to call that the ST segment. We'll come back to it. And then there's a T wave, which is ventricular repolarization of the myocardium. Okay. Notice you don't see atrial repolarization because it's small and it's buried in the QRS complex. Okay, so we wouldn't ever see atrial repolarization on the electricity of the heart because it's somewhere in that QRS complex and it's too small to see. Okay, so those are the main waves. P wave, QRS complex, T wave. Those are the main ones. Okay, let's move forward. Okay, so on this slide, we're going to talk about the normal electricity of the heart. Okay, where it starts, where it ends up, and why are we talking about electricity? Because electricity is what generates contractions of the chambers of the heart, so the atria and the ventricles. And that allows for movement of blood, right? So from the atria to the ventricles, when the atria contract and when the ventricles contract, the right ventricle moves blood to the lungs through the pulmonary artery, and the left ventricle moves blood into the systemic circulation. Okay, so let's look at just normal electrical conduction. So we have a little bundle of nerves called the sinoatrial node in the top right corner of the right atrium, and it's what we call an automated pacemaker, meaning it can regulate its own depolarization and regulate the heart rate. Okay, so it's constantly being adjusted. Say somebody has a rate of 60, and the body, through the autonomic nervous system, so the parasympathetic and the sympathetic, want to increase the heart rate. Well, you can have a heart rate of 70 or 80 or 120, depending on what the nerves that are supplying the heart are stimulating. Okay, so the sympathetic nervous system increases heart rate and also increases conduction through all the nerves, but we're talking about electricity here, so increases heart rate. The parasympathetic system decreases heart rate. Okay, so anyway, so the SA node is where the electricity is generated spontaneously, this little bundle of nerves, and then it travels right across the atrium. Okay, both atrium, left and right. So we could call it the interatrial pathway, which is what's seen here. And it ends up at the AV node, okay? The atrial ventricular node. Now, that electricity that's gone over the atrium is going to result in an atrial contraction, right? So an atrial depolarization causes the myocardium to contract in the atrium. Okay, so now the electricity has arrived at the AV node, okay, and it's going to be held there for a short period of time, and we'll talk about that later. Why is it held there for a short period of time? And following that, the AV node is going to release the electricity into the bundle of His. Okay, so the bundle of His, it's not labeled here, but it's between the AV node and the left and right bundles, and you'll see that blue line between the AV node and the left and right bundles. That's called the bundle of His. So now we're into the ventricles, but still in a nerve fiber called the bundle of His. That branches into left and right bundles, each going to a ventricle, and finally the left and right bundles are going to get smaller and smaller and smaller and branch out more, and we'll call those Purkinje fibers, which are still nerve fibers. And finally, all those little nerve fibers are going to surround both right and left ventricle, and they're going to depolarize the myocardial cells. So it's like a fine meshwork of Purkinje fibers around the ventricles so that they depolarize at the same time. Okay, so it's getting that electricity to both ventricles really quickly, so they contract at the same time. So I really want you to keep this nerve pathway understood well, because when we talk about arrhythmias, the electricity isn't necessarily going to follow this normal pathway from SA node to both atrium, to the AV node, down the bundle of His, to both bundle branches, the Purkinje fibers, and then the ventricular myocardium. It's not necessarily going to do that. So have a really good understanding of what normal is. And this is normal, okay? The other thing I want you to remember is the AV node is the only normal connection of electricity between the atriums or the atria and the ventricles. There shouldn't be any other way of electricity getting to the ventricles other than the AV node. So the AV node is kind of the guard of the ventricles with respect to electricity, because it's the only way electricity should be able to get through. Okay, when we're talking about influences, influences of heart rate and contractility, that's the autonomic nervous system, right? The parasympathetic, slowing it down, reducing heart rate, and the sympathetic, increasing heart rate, increasing contractility. Okay, contractility means how forceful are those ventricles contracting. Okay, and the sympathetic system increases contractility. So we're going to talk about heart ECGs in terms of how we obtain them, what the components of them are, and how to analyze them. Okay, So we'll move on from this slide. Okay, so on this slide at the top, you'll see two terms being used, arrhythmia or dysrhythmia. They mean the same thing. So an arrhythmia or dysrhythmia can be a heart rate that's too fast or too slow, or it's not regular like it's supposed to be, right? So, so think of an arrhythmia is, okay, a heart rate less than 60, a heart rate greater than 100, or it's not really following the normal electrical conduction of the heart, and we're going to call it an arrhythmia because of that. Okay, so fast, slow, irregular rhythms, rhythms that don't typically follow the normal pathway, and we call the normal pathway that we just discussed normal sinus rhythm. Okay, so we'll come back to that. Okay, so let's just look at some signs and symptoms that can occur if someone has a very slow heart rate or a very fast heart rate, or a rhythm that's very irregular, say, and there's missing beats, and it's just not following normal sinus rhythm. Well, the first thing is when we have someone on the monitor, we need to assess the patient first, right? We need to assess their airway, breathing, circulation, and by circulation, what's their heart rate? What's their blood pressure? Okay, because the monitor is just giving us the electrical readout of the heart. It doesn't actually tell us how the heart is contracting. Is it contracting with lots of force? Is the electricity actually even turning into a contraction? Sometimes it doesn't, and I'll give you an example of that later. So electricity on a monitor does not mean that there's normal contractions of the heart, okay? That's what it's supposed to do normally, but that's not what it always does in a patient. Okay, so we have to look at the patient first. And when we're looking at a patient, we're looking for any signs or symptoms of decreased cardiac output. So what is decreased cardiac output? Well, cardiac output is heart rate times stroke volume. Okay, stroke volume is how much blood is pumped out of the left ventricle per beat. Okay. And the reason why we're looking at signs and symptoms for reduced cardiac output in slow rhythms or fast rhythms is when you have a very slow rhythm, well, your heart rate's slower, so your cardiac output is going to be less. When you have a super fast rhythm, sure, your heart rate is faster, but your stroke volume is diminished because the heart's beating so fast that it doesn't have time to fill with blood during diastole. Okay, so cardiac output can be diminished in bradycardia and in tachycardia. So what are the signs? Decreased level of consciousness. Why? Decreased blood pressure, right? So we're going to be dizzy. We're going to be confused if our blood pressure is low because the brain needs blood. Hypotension. Okay, I don't think I'll need to explain that one. Hypotension from reduced cardiac output. Cold, pale extremities and weak pulses. Well, that's the sympathetic nervous system saying, well, the blood pressure is low and I'm not happy about it, so I'm going to vasoconstrict the blood vessels to non-essential organs such as the skin. So I'm going to be pale, cold, sweaty, okay, and weak pulses because of reduced cardiac output. Decreased urine output because the blood pressure is low and it's not perfusing the kidneys. That's going to trigger aldosterone to reabsorb fluid, right? Keep all the fluid in the body, and that causes decreased urine output. Dizziness would be the same as decreasing level of consciousness. It's because of poor blood flow to the brain due to low blood pressure. Okay, so this next slide is showing you the different ways that we can set up leads on someone's chest, depending on what we want to monitor. If we just want to monitor, say, somebody's rhythm in the emergency room, well, we can set up a 3-lead setup, right? So there's just 3 leads on the chest: right arm, and left leg. And that's just going to give us on the monitor a readout of their rhythm. PQRST, PQRST, and so on and so on, assuming it's normal sinus rhythm. Okay. If it's another rhythm, well, we'll see that on the monitor. A 5-lead setup is typically used, say, in a telemetry unit or in the ICU, where they're just able to get more different views of the rhythm. Okay, so they can see the rhythm in different directions because there's 5 leads on the chest, and they can switch to a different lead and see the electricity in a different direction. That's all it is. Okay. And with telemetry, often patients are able to carry it with them. They're able to walk around if they're allowed to do that. Sometimes they're in the bed and they're on a monitor attached to the wall that then sends the monitoring to the nursing station, or they have what's called a telepack that they're carrying around, and the information is still being relayed to the nursing station. A 12-lead ECG is going to give us multiple views of the heart. That's all we're doing. And why do we get an ECG or an EKG? Well, not only do we want to see the rhythm, but we want to see different parts of the heart in terms of whether there's any damage, okay, or any ischemia or infarction, a heart attack. Okay, so an ECG is going to give us different views of the heart. For example, we can see the bottom part of the heart. We can see the left side of the heart, the right side of the heart, the back side of the heart. So, because why are we doing an ECG? Well, we're doing it looking for the rhythm, or looking at the rhythm, and we're doing an ECG with someone who comes in with chest pain. We're looking for ischemia or infarction. Okay. Sometimes we'll put leads on the back of someone's chest. Those 3 leads you see in the last image. Well, we peel off V4, V5, and V6 off the normal ECG in image 3, and we take those 3 leads and we stick them on the back, and that allows us to look at the back of the heart. Okay, so that's all we're doing with placement of these leads. We're just looking at different views of the heart, and the general setup is a lead at the right arm, and it can be anywhere on the right arm, the right shoulder, all the way down to the wrist. Left arm, right leg, and the right leg can be from the hip down to the ankle. Left leg, and finally the ones that are going right across your chest, V1 to V6. Okay, so just get the general idea of how an ECG is set up. Okay, so I mentioned this on the slide above. Continuous cardiac monitoring. Well, that's someone who's in bed. We have them set up with leads, and the leads are going to the monitor above them, and they're also going to the nursing station. Okay, so in the top left image there, you can see someone monitoring different patients and their rhythms. Okay, so continuous cardiac monitoring. Telemetry is still going to give you that information, but the patient can be mobile a bit. Okay, they can be walking around a bit with a telepack. Okay, 12-lead ECG is the bottom left. Okay, that is what we get from putting all those leads on a patient. Those 10 leads. Okay, right arm, left arm, right leg, left leg, and then the chest leads, V1 to V6, and we'll talk about those. Okay, Holter monitor. Well, a Holter monitor is usually a device that someone wears for 24 to 48 hours. Sometimes patients can wear Holter monitors for weeks, and it's monitoring every beat, and we're looking for abnormal rhythms too fast, too slow, irregular. And typically, a patient will come in, say they're complaining of dizziness or they're fainting, and we can't find anything. We can't find an abnormal rhythm, um, and they're feeling fine at the time. Well, we can set them up with a Holter monitor to go home with, and once they're finished the 24 or 48 hours of monitoring, and they just do their regular activity, they go about their regular day, okay? They return the device, and the computer will give us a readout of every beat, and whether there were episodes of dysrhythmias, whether there were extra beats, missed beats, fast rates, slow rates, all that information. So it's very useful for arrhythmias. Okay. Now, if someone goes home with a Holter monitor, we tell them just to go about their regular day. Do whatever you do on a regular day. Don't don't stay in bed. Uh, don't do things that you usually wouldn't do. Just go about your day, and we're going to try and catch the abnormal rhythm on the monitor. Okay? There's actually a button on that device at the bottom right, where if someone has, say, palpitations, or they felt dizzy, or they fainted, they can press a button so that the computer knows to really look at that area um, once they've returned the device to see if there was some kind of arrhythmia during their symptoms.